Welcome to the Sonosite webinar on diagnostic shoulder exams, the superior shoulder. Before we begin, please be advised all attendees are muted. You may type your questions into the Q&A box located at the bottom or side of your screen at any time. We will conduct a Q&A session at the end of the presentation and live demonstration. This webinar will be recorded and archived for future reference. With us today, we have Daniel Shelton. Daniel Shelton is the Director of Musculoskeletal Market Development for FUJIFILM Sonosite. Daniel spent 16 years as a dedicated musculoskeletal sonographer, and 10 of those years have been here at Sonosite. He now leads musculoskeletal market development, where he works to spread the word about the benefits of point-of-care ultrasound. Daniel, I will turn it over to you.
Thank you, Laura, for that introduction. As Laura mentioned, this is the last part of a four-part series on the superior shoulder. There's not a lot going on the superior shoulder, so we'll throw in like an extra slide or two about a couple of bonus structures in the area that I found to be really fun while I was scanning in the superior shoulder region anyways. But first, we will stick with the acromioclavicular joint as a primary protocol structure of the shoulder. It should be looked at anytime you're evaluating shoulder pain. So just to give you an idea of the journey we've been through here, we started on the anterior shoulder, worked our way down through the lateral structures, such as the main rotator cuff of the supraspinatus and infraspinatus and subscapularis, and their various insertional variants and what we look for. And then we went to the posterior shoulder for the infraspinatus and teres minor, and also looked at the labrum and spinoglenoid notch. Today we'll be looking at the top side of the shoulder, the acromioclavicular joint. And then while we're in that area, we're just going to translate the transducer a little bit anterior, and we're going to aim the beam somewhat towards the coracoid, and we're going to be scanning the suprascapular notch. So just knowing that that could contribute to other pain generators in the area. So we'll keep it short and sweet today and rely heavily on Q&A. And just remember, this is the last of a four-part series. If you missed any of the previous webinars, they are posted at sonosite.com. And you can check out those webinars in their recorded fashion. Looking at the anatomy here, we're scanning primarily over our landmark of the acromion. I think that's the easiest to palpate if you're looking at an obese shoulder. So I tell people to poke a finger down on the back side of that transducer and feel for the acromion process, and then start from there, even if you have to go as lateral as the subacromial bursa. And then work your way up towards the anterior lateral shoulder while the probe is standing up about 12 o'clock. And you should see a break in that acromion. And at that point, you need to translate and twist your transducer until you see the clavicle. Something to keep in mind when we're doing AC joint evaluations is that this space should have a normal meniscal homologue inside, which is a fibrocartilage disc. That stays there when we're young and it disappears when we're old. So it can contribute to what looks like a loose body or something clicking or popping inside the joint when we do a dynamic exam. And to stress this joint, there's a few maneuvers we can do, but the most common is here, where we have the patient touch their ipsilateral shoulder, or contralateral shoulder, sorry, and we get those two bones to kind of clap together. And this way we want to look for the joint symmetry. Does the joint stay level? What's the integrity of this ligament here? The joint trying to sublux? Is that little disc popping out? Do we have osteophytes inside, or osteolysis of the bone? Do we just synovitis or inflammation in the area that could be treated? There's a lot that can be discerned in shoulder pain at the AC joint level. It's very tender, and you want to use sonic palpation at this point. If you suspect something in the ligament or something deeper on the insertions of the ligament and that fibrocartilage disc, you may want to switch frequencies to the linear 19 megahertz probe that we'll be scanning with a little bit later if we have time. You can also stress the elbow by pulling down on the elbow and do kind of a weight-bearing exam on the AC joint. And that can be helpful for AC separation, just checking out the stability of that ligament again and seeing if the joint opens up or gaps. I'm going to move on to the suprascapular notch. So this was a really fun structure to learn, and once I had it taught to me, it was kind of one of those things that you can't unsee. While you're in the area, you might as well just plop the probe a few more, like 2 or 3 centimeters midline and aim the beam anteriorly and just see what you can see, and look at the supraspinatus muscle, which we discussed in the lateral shoulder webinar and the posterior shoulder webinar for atrophy. But if you have not explored the anatomy of the supraspinatus fossa down at the bony surface, this is a great time to kind of learn that landmark. Instead of making this webinar 3 minutes long and talking about the AC joint real fast, I figured we would just explore one other thing. So if this is not an interest to you or whatever, that's okay. But there is a lot of people out there that they've explored the shoulder in pretty good detail, but maybe there's just one or two things here and there that they would like to learn just a little bit extra. And I think this is one of those structures that does that. So this is a really superior view. Think of that Netter's view of the rotator cuff. We're looking down on the body. We're looking down on the shoulder. So here's the AC, the supraspinatus going underneath it in the supraspinatus fossa. We can see the beam is planted midline to the supraspinatus, which is like mid-coronal to the body plane. Patient positioning doesn't really matter. The patient can be nice and neutral for this exam. And my tip, and we'll show this tip while we scan, is to look at the posterior edge of the probe on the anterior edge of the spinous. Sorry, I'm going to back again, of the scapular spine. So.
This is Laura. I'd hate to interrupt you, but we're having some audio issues. It keeps kind of going in and out. So I don't know if there's something going on your end.
Let me move this microphone. Give me 2 seconds.
Okay, thank you. Well, please, everyone. We'll get right back in just a moment.
How's that? Any more clear?
That sounds better. Yeah, it was sounded like a connection issue. It was like clicking, but
I may not be able to help much of a connection issue. So yeah. I'll try. Maybe it's lucky this is a quick webinar, right? Maybe my internet's about to go down. Who knows? Everybody's so used to this after 1.5 years of Zooming. It's pretty shocking. We haven't had worse problems, Laura. But thanks for giving me that heads up, and we'll trim that out of the recording. But anyways, I'll go over the live scanning tips and how to find this. Just know that we're looking for this structure at the supraspinatus fossa here, this little notch and ligament, and there's going to be a nerve that passes through there. That's a suprascapular nerve. You do want to throw on your color Doppler, whether it's power Doppler or the directional flow, it doesn't matter. But we want to locate this little artery, the suprascapular artery, and find out if that artery goes above the ligament or below the ligament, because there are some anatomical variations for that. And you can do therapeutic injections, or you can do diagnostic injections at this level. So this can be a part of your shoulder diagnosis, while not in a rotator cuff protocol manner, in a ultrasound guided needle injection around this nerve to see if that patient's pain generators go away just at isolating that suprascapular nerve. So this can be a great tool to kind of pull out of your toolbox if you've run out of other options. So what we're going to do now is just go over to the live demonstration, and then after the live demo, I just want to let you know that there's plenty of time for Q&A, and if you guys want to go ahead and have any questions ready in the chat portal, now's the time to start typing those. But I'm going to make this transition to the live scan, and just give me 1 second. Okay, so now we'll begin with the live shoulder demonstration. Today we're going to be looking at the superior shoulder. Just like we had in the PowerPoint, will be the AC joint, and then we'll take a dive into the suprascapular notch and some of the other structures in that area. We'll be scanning on the Sonosite PX ultrasound system, beginning with the L15 to 4 50 millimeter head, and then we'll move over to the L19, which is a 19 to 5 very high frequency transducer. So first we'll get started at the AC joint, and I'll talk a little bit about palpation first. On most patients, you can either start at the scapular spine and work your way forward until you can't feel anything else. So right here, I'm just kind of walking my fingers until I reach a bony stopping point. At that point, the acromion is taking a slight turn, and the clavicle is meeting it at that turn, creating the AC joint. So we should be able to set the probe right down in front of where I feel the spine of the scapula stop. To do that while I scan, I'm going to keep the left side of the screen to my patient's right. I'm going to hang a finger down on the back side of the transducer and use it as a palpation point right there in that little corner that I'm palpating right here. So I'm going to set that down and just place the transducer right in front of that palpation point. And we get that really nice AC joint superficially. So that's just a good starting point by placing your finger back there. You can leave your finger back there, that's fine. But what we're going to be looking at right now is a few dynamic maneuvers to test this AC joint, and keeping your finger plopped down in that area may also help keep you stable. So screen right, pull my arrow up here. There we go, screen right. I've got the clavicle side, and I can see the trapezium starting to come over and invade the picture there. And then screen left, we have this bright cortical landmark, which is the acromion process. And then we can see the deltoid tendon attaching on the acromion here. So just under the deltoid here, we could see the subacromial space, which was described in the lateral shoulder webinar. So we won't go into too much detail here. But if you wanted to confirm your placement there, we could just have our patient do a slow kind of chicken wing maneuver and then watch that subacromial space glide really nicely. Here's also a good time to see if that's contributing to any clicking or popping around the AC joint. That way you can kind of modify or tailor your exam to also include that subacromial space. So go ahead and relax. There we go. Now let's go right back following that acromion towards the clavicle here. We can see that very, very superficial structure, the AC ligament. And we're going to test the integrity of that ligament. And there's also a little meniscal homolog here right in the joint. That will degenerate as we get older. And right now I'm seeing a nice healthy joint space. So what we're going to do is see if that meniscal homolog inside the joint wants to protrude out with any dynamic motion. So what I'm going to do now is have our patient just reach over and touch her opposite shoulder, and let's watch those two bones. Now notice they stayed nice and level. That's normal, that's great. What I don't want to see is either of these bones kind of sublux over the other. I see the AC ligament is perched up high, which is also normal, and it's the ligament and that meniscal homolog are bunched together. So go ahead and relax. There we go. And then the second maneuver I'm going to do is try to separate her AC joint by pressing down on the forearm here. So she can just keep her arm in her lap, and I'm just going to use pressure after the elbow bend, and I'm just going to press down. There we go. And what that does is help me pull on the actual elbow joint. There we go. And I didn't see any separation. So those are kind of the two main diagnostic maneuvers you can do to test the integrity of the AC joint. Let's take a closer look at this ligament here, the AC ligament, by switching over to the 19 megahertz linear, which is a smaller footprint. It's going to be a little bit more zoomed in. So this transducer, it begins zoomed out for perspective. That way we don't get a little overwhelmed with what we're seeing in the shot, overly zoomed in. There we go. And then we will slowly creep our depth up so that we can appreciate all these little fibers. But if we do suspect calcium deposits or little avulsions or any other osteolysis, this is the transducer that you want to use. So I'm going to bring my depth up and my gain up just a little bit. Got our arrow back up. We can see that AC ligament really nicely. We can see its insertion and origin also very nicely. I don't see any calcium deposits or any avulsions. That's something that I'm looking for. You can redo those dynamic maneuvers at that point. Also turning on your color power Doppler at the enthesis or the origin of this ligament is very helpful if you suspect some sort of avulsion or other traumatic pathology in this area. At 19 megahertz, we can see the integrity or the internal contents of that meniscal homolog very nicely, and just get a very, very close look at it. Also for a procedure, I would recommend this smaller footprint transducer to kind of narrow your margin of error when doing an injection. You can typically do these out of plane. We have a nice arrow right there on the center of the screen, center of the transducer, and I'm just going to activate just a center line. Here we go, right there, center of the screen. And that's going to correspond with the arrow underneath the transducer. So it's typically out of plane because it's so shallow. Or what I also see a lot of people do is build up a sterile gel on the lateral side of the transducer here. So you build up sterile gel, you have your transducer covered, and then people will tilt the probe up and just drive their needle here through the sterile gel and puncturing that ligament down into the joint. If they want to see the needle in its shaft and bevel in its entirety, that way once you pierce that ligament, you can spin and go bevel down and watch the injectate pour into the joint. But I would say 90% of the time most people just drop the needle out of plane, but for those that really want to see the needle go in long axis to their target, this is the typical approach. Right here you can see my finger, it'll start coming in under the right side of the screen, kind of representing the needle's path. So from an AC joint standpoint, that is the extent of the exam, really. There's not much to see in cross-section of this joint, and so it's not typically done. I'm going to go back to my L15 transducer, which has a larger field of view, and we're going to look at the suprascapular notch. So I'm going to follow the scapular spine, which was a great palpation point earlier. I'm going to set the transducer right on the scapular spine, so you can see that superficially right here. Nice scapular spine, and I'm going to aim the beam towards her coracoid. I'm going to keep the probe on the scapular spine, and I'm just going to walk it towards the coracoid. All right, so here you notice I don't have enough depth. All I see is muscle. This is trapezius. This is supraspinatus muscle. I'm going to turn the gain up just a little bit. And I want to prove that supraspinatus by having our patient just do a little chicken wing maneuver, and we'll fire that supraspinatus in abduction. And then back down to the ribs. Good, just hold that. So I need to see the supraspinatus fossa. I'm going to fire the transducer down a little bit deeper, still aiming the probe slightly towards the coracoid process. There we go. And I can see the bottom of that supraspinatus fossa. If you're having a hard time seeing the bottom of your patient's supraspinatus fossa with good clarity, I advise you to drop your frequency for a linear array transducer going through a lot of trapezius and then through the rest of that depth on the neck. Sometimes you have to lower your frequency. So on the Sonosite PX under the MSK exam type, I'm going to select Gen mode, and you're going to see the bottom of the screen brighten up pretty good. There we go. And I think that clarifies that suprascapular notch a little bit better. So here's our notch. And then what I'm going to do is I'm going to aim the probe anteriorly, and then I'm going to sweep it posteriorly. So anteriorly, we see it fall off because I'm just about at the coracoid process itself. And then I'm going to go posteriorly until I see that notch form in the fossa here. That's where we should see a little pulsatile artery, and we can check our work with the artery that follows the suprascapular nerve by throwing on our color power Doppler. I'm going to hit the C button on the PX here, and I'm going to drop our color ROI right there. And I have the directional color on by default. I'm going to switch that to color power Doppler with just a button press there. And it should be very dialed in for musculoskeletal blood flow. You shouldn't have to do a lot, but what I like to do to make sure I'm getting the most sensitive setting for my color power Doppler is I bring my gain up until I see noise underneath the bone. So this is all just noise that we're seeing under the bone. Get my arrow to move around. All this little twinkling that you see under the bone is not real flow. I'm going to suspect that this pulsatile steady structure is above the bone, and just to check that, I'm going to reduce the gain underneath the bone until that twinkling color goes away. And there we can see that suprascapular artery right there in the notch really nicely. And we know that that suprascapular nerve is going to border that artery, so that we could use that artery as a guide. If you're going to drop your needle down to this level, you know what to hit and what not to hit. If you're doing a deep procedure, this is also a good time to activate the color compare feature on the Sonosite PX. I'm going to select top bottom, so I activate the entire transducer, but here you could drive your needle in real time and see where the color was on the screen, indicating where the artery is versus where your needle might be in grayscale, so that that ROI box and any flash artifact that's showing up is not showing up in your image on the bottom. So the bottom is a live indicator of what's happening on top, and if you're doing a very detailed procedure that requires some sort of arterial landmark, I really do recommend using the color compare tool to drive your needle and also observe where not to put your needle, like in the suprascapular artery here. That's the most common view, but what I'm going to do is just rotate the transducer. Left side of the screen will be anterior. We're going to get a short axis shot. I'm focusing on the bottom of the screen so I don't get all that arterial flash. And I know that the screen left is anterior, so I expect that artery to show up right there on that neck of the coracoid. Is going to start dropping itself right across that slope. There it is, of the supraspinatus fossa. So here's that same suprascapular artery. The angle we were taking earlier is leaning the transducer from the spine of the scapula anteriorly into the wall of the supraspinatus fossa, right as that suprascapular notch forms right here. So we were taking a very hard oblique angle there, and it's kind of nice to see this top bottom where the artery is not in my way. If I were doing a procedure, I would know what to miss and also get a good clear shot of the needle. I'm going to turn off the color compare so we get a full screen. There we go. And a nice look at that artery, as well as the nerve, which is just resting on the bottom of the screen here. There, laying underneath the muscle belly of the supraspinatus. So this whole round structure here is supraspinatus muscle belly. This is a fascial plane that goes between the trapezium, which is transverse here, so this is all trapezium. And, or trapezius, I should say. And then here's the trapezium's in the wrist. Trapezius muscle superficially, and then supraspinatus deep there. Diagnostically, if you're doing an exam on the supraspinatus, as we covered in the lateral shoulder and posterior shoulder, I think we briefly touched on it, this muscle should be nice and dark all throughout, all the way up to that fascial plane. You shouldn't see a dirty shadow or rim around the muscle belly. It should be nice and dark right up to the fascia. So that kind of, that really concludes the majority of what we do when we're looking at a superior shoulder exam, plus a little extra. Going into the suprascapular area is kind of bonus. It's one of those things that once you see it, you can't unsee it, kind of anatomy. And you do go kind of check that area out every once in a while, just to see if, hey, maybe there's something invading the area of that suprascapular nerve that you could go check out, like a cyst, maybe a superior labral cyst or something that might be spilling over, because here's that superior labrum right there. You won't see that on everybody, but here's the shadow of the acromion. Here's superior labrum, kind of where the origin of the proximal biceps is. And then here's the superior glenoid tubercle, and then here's that neck of the glenoid, and then here's your suprascapular notch. I thank you for joining us. That concludes the content of the webinar. We'll move on to the Q&A session. If there's any questions, we'll go ahead and answer those now.
And we do have a question. Are impingement signs helpful while doing scans?
Absolutely. So as I mentioned right when we got started, find that acromion process right there and move laterally until you see that humeral head. When we see the humeral head, you want the acromion in the shot as well, so that can be a little tricky. I find that getting the impingement maneuver, if you're trying to scan based on traditional anatomical location, which is the palm forward, the greater tuberosity does go more lateral and makes it a little easier to find if you're looking at an anatomy reference. There we go. So at this point, if she were to slowly chicken wing up there, and then sometimes you can even have the patient rotate their hand this way and try to do that empty can test. And then let's go palm up. And we're looking for any clicking, popping, grinding of the face right here. Let's go back down to her side. And that's the subacromial subdeltoid bursal interface. And hers is normal. And we're still seeing it because the Sonosite PX has such a high image quality. On your machine, you may not see that thin black line interface, and just know that's normal not to see that. It's nice to see that when you do have a really nice machine, but let's point that out. So I zoomed in a little bit. So here's the acromion, here's the deltoid tendon, right? So this is a tendon of the deltoid muscle. Here's the muscle of the deltoid. This is the subdeltoid fascia right there. So it's connected to the overlying deltoid. Underneath that is a layer of peribursal fat. And then in this little interface here is the actual potential space of the bursa. Underneath that is peribursal fat. And then we have a peritoneum of the supraspinatus, and we have the supraspinatus. So there's a lot of layers here, and using ultrasound to discern, hey, is it a real bursitis, or are there adhesions in there? We can evaluate this entire interface really nicely. So I'm going to have our model here today just chicken wing up a little bit, or abduct. Let's watch that, and then back down. And you get to see, hey, once that tuberosity clears, you're good. Another scanning tip, if you're in this area, is to put the weight of the transducer right up here on the acromion. Don't put the weight of the probe on the deltoid. So we covered that in the lateral shoulder webinar at depth. We actually went over lots of scanning techniques for doing the subacromial, but I will say real quickly while we're here, if the weight of your probe is on the deltoid too far laterally, when she abducts, the contracting deltoid is actually going to bump my transducer and make it very hard to follow. And another thing that can happen is the pressure from the transducer will get translated through the deltoid and collapse the subacromial bursa. Mm-hmm. So if you place the weight of the probe on the acromion, you eliminate the pressure that the transducer puts on the bursa. So we don't want to deflate the bursa if it's going to be inflamed and inflated with fluid, right? So put the weight of the probe right there on the acromion that we're seeing here on the screen, and then do the abduction. Don't worry about this air gap out to the side. That actually shows me, if I'm the one looking at your pictures, that you're not applying too much pressure, that you do not have the weight of the probe over the deltoid. So while it's not a real pretty picture to leave the air gap out there, it's fairly useful, for somebody that's helping you read your images or whatever, that you're not collapsing the bursa with the weight of your transducer. But ultrasound is absolutely used for impingement of the shoulder of all kinds: subacromial impingement or subcoracoid impingement, the subacromial bursa impingement, and other adhesion pathologies in the shoulder.
Great, and we actually have a few more questions coming in. You just mentioned the subcoracoid bursa. Can you highlight that on a scan as well?
Sure, I'll do my best because they're best seen when they're abnormal.
Right.
So we're here on the front part of the shoulder. I'm going to go back to the biceps tendon that we normally would do, right? And so we have our patient with their arm in her lap, her palm is up, and if you're new to scanning the shoulder, the handle is roughly in line with the forearm, so that when she externally rotates here, the biceps groove goes with the forearm. See the correlation there? Mm-hmm. Mm-hmm. So I'm going to follow the subscapularis now here, anteriorly. And what you might not have seen my hand do, the medial side of my probe, once I followed anteriorly, I had to bring the medial side of the probe north to see the coracoid. So if you're just chasing the subscap, you may not see the coracoid. You're going to see that round oval down there of the coracobrachialis and the short head of the biceps coming up to the coracoid. But that shadow right there has a cortical margin and then a shadow. So don't just look for the big dark oval. That's not the coracoid. You have to bring the medial side of the probe up north. And now we're going to look for this interface. Much like we just did the subacromial, we're going to slowly internally and externally rotate. And she's going to go all the way in until the lesser tuberosity clears the coracoid. And let's externally rotate again. And I didn't see the lesser tuberosity clunk into the coracoid or its surrounding connective tissue right here. And that's moving nice and free. So if that gap right there were more narrow, that lesser tuberosity would grind on all this connective tissue underneath the coracoid, and you'll actually see a really nice bursa there as well when it's inflamed. Today I don't see a bursa. I hardly see a bursal interface because it's normal. There's really nothing to see here.
What about the subscapularis bursa?
So as a subscapularis having its own isolated bursa, that could just be another obscure name for the kind of tear dropping forward of the main subacromial subdeltoid bursa. So the subacromial subdeltoid bursa, a big teardrop that extends on the extreme lateral side and extends this way. It also has communication anteriorly too. So you can call that subscapularis bursa, or if there is an isolated bursa far away from up here, you could call that subscapularis bursa as well. But I honestly have never seen a really isolated subscapularis bursa that I could not trace back up to the subacromial in some way, like a little teardrop communication still going up to the main bursa. But it would live just right there on top of the subscap, underneath that subdeltoid fascia, just like we look laterally. It would live here if we could see it, but that's another one of those bursa that is not going to be seen unless there's something wrong.
Right.
Great question.
Okay, and someone's asking if you could scan the supraspinatus again.
You bet. So we'll go from anatomical position. So if you're looking at an anatomy book and you're new to ultrasound and you're pulling out anatomy references, this is one that will, this one's tough. So what we're going to do is I'm going to put the notch of the transducer, I'm going to flip it from how we've been scanning so that it looks like an MRI, okay? So the left side of the screen will be the patient's lateral side or right side, just like it would be an MRI. So we're going to correlate this as much as we can. So we have the, no, that's how I was scanning earlier. Okay, good job, Daniel. Here's the acromion, here's the humeral head, and here's the greater tuberosity. Here's the supraspinatus, and then here's that subacromial subdeltoid bursa. But I can't see the remaining fibers of the supraspinatus. So we have to do a few things. We need to have the supraspinatus be pulled out from that shadow of the acromion, right? I can't do that if she just moves her arm. I can see more of the tendon, maybe a little bit more of the tendon, but I still am overshadowed by the acromion. So what we have to do is bring the elbow back. Okay, when we do that, the ball of the shoulder is going to roll anterior and the greater tuberosity is going to drop inferiorly all the way to here, okay? And if you're not real familiar with the greater tuberosity landmark being anterior like that, and you want to kind of prove it to yourself, go find the biceps tendon because they're neighbors. Remember, we're internally rotated, and I talked about the biceps earlier. The groove is going to be in line with the forearm. So her forearm is pointed to her chest. Mm-hmm. That means the biceps tendon is this far medial. And I'm going to cut it in half, and we're going to look for the biceps tendon in its groove. And there it is, down here, exiting the biceps groove and coming up into the rotator cuff interval here. Okay, I'm going to have her elbow come to her spine. Maybe she has to scoot forward a little bit. There we go. And then where's the upper camera? There we go. Scoot that forward. Okay, so when I had her elbow go towards the spine, what that allowed the shoulder to do, the glenohumeral joint, is externally rotate enough to bring the biceps more comfortably for me to image, probably not for the patient, laterally. Okay, so here's our biceps tendon, here's our supraspinatus tendon, that's the superior facet here, and the middle facet of the greater tuberosity. So we're looking at the coronal equivalent of an MRI, sagittal, sorry. So this is the sagittal equivalent of the MRI of the footprint of the supraspinatus and infraspinatus. And we know this is supraspinatus here because the neighboring structure here is biceps tendon, and then there's some rotator cuff interval structures here, but we've got supraspinatus and short axis. This is at the enthesis, or the greater tuberosity footprint, and what I'm going to do is just pull the probe proximally until I see humeral head. So here's the humeral head with cartilage, and this view is kind of cool. It looks like what's called a wheel in a tire. So we see an inflated tire on top of a wheel, and it's full of volume. If there's a rotator cuff tear here, we're going to have volume loss or a flat tire. So keep that in mind. We don't have a flat tire here. I see articular hyaline cartilage, that black rim capping the cortex of the humeral head, and I still see my biceps tendon anteriorly. So my neighbor is the supraspinatus right here. And bringing my gain down a touch so you can see the layers of the supraspinatus and the corco, humeral ligament, all that complex is right here. Now what I'm going to do is I'm going to take my transducer and slice the tendon this way by rotating it 90 degrees, bringing the left side of the screen lateral here, and we're going to look for that footprint again of the greater tuberosity. And when you're scanning this, stay 90 degrees to the cortex of the humerus. That's the big deal. You'll never be lost if your bone is nice and bright. These structures are wrapped around the ball-shaped humeral head, and as long as you're imaging the cortex of the humerus as bright as you can get it, you're getting an accurate image of the tendon. So this is an anisotropic structure, the supraspinatus is. This dives into the greater tuberosity here, so that diving, we get an angle artifact at the deeper part of the supraspinatus tendon right here. And when it dives, the ultrasound beam reflects away instead of reflecting back. So it kind of ricochets off. We have to correct that angle ourselves by tilting the probe to be level with these tendon fibers. So that was not a tear, and it wasn't a tear for a few reasons. The cortex was smooth. Most of the time you see a tear here, there's a disruption in the cortex. I didn't see volume loss in that inflated tire overhead, right? So there's no volume loss or dip of the deltoid into the rotator cuff here. And so that was 2 key indicators there. And if you thought there was a tear, you can lean your hip, I won't do it for the camera, but you can lean up against this elbow and have your patient push the elbow against your hip or side or your hand. And if you don't see the tendon pull back and retract off the cortex of the greater tuberosity, that is probably intact and not a tear. You're just looking at the anisotropic artifact right there. So if we want to prove our work, is this supraspinatus? I'm going to go find its neighbor, the biceps tendon anteriorly again, which is down here. So this little arc shape is biceps, and I'm just going to pan the probe laterally until we see the anterior margin of the supraspinatus. But supraspinatus, those are the scanning tips and things to kind of stay away from that work very, very well. You can relax. Don't forget to tell your patient to relax on that one.
So we have kind of a 2-part question. The coracoclavicular ligaments and a bursa above the clavicle. Is that something you can show in this webinar?
I've never scanned a bursa over the clavicle. I'm sure there is one there, but it's not one that I've been versed in looking for. So that's not one that I'm going to be versed in talking about here today. I've never seen one clinically. And I have not seen one in any of the major references for ultrasound that there is to study. But let's look at that coracoacromial ligament. So we've got left side of the screen, I've got towards the acromion, and I have the right side of the screen towards the coracoid. So let's find the coracoid first here on the right side of the screen. And then what I'm going to do is swing my thumb side of the probe north, okay? I'm going to keep the left side of the screen pivoting on the coracoid, but I want to bridge that gap to the acromion there. And mainly, I'm angling almost 12 o'clock back into the shoulder, and we want to see this ligament here. So this ligament bridges that supraspinatus tendon and muscle at this point. And if I get it at the right angle, we can actually see there we go, the ligament and the supraspinatus muscle belly here. So here we have our coracoacromial ligament. You can see this hypoechoic stripe right here. Mm-hmm. And what I don't want to see is it flatten out or dip, because that would mean we have a lot of volume loss of this supraspinatus right here. So I like that it has kind of this convex appearing arch. That means there's volume of the supraspinatus down there. You don't want to see that ligament laying any lower there. But you can do dynamic maneuvers at this point and see if that has any adhesions, and that's an internal and external rotation. When she externally rotated, the subscap muscle perched and bowed up this coracohumeral ligament here. So here we have the coracoacromial ligament, and then underneath this little spot, obliquely coming in from the other side of the coracoid here, this rounded structure is a transverse coracohumeral ligament, and we can elongate that as it drapes over to the greater tuberosity and overlying the biceps at the interval. So there's your long axis coracohumeral ligament also.
Great. And one more question. Can we see the upper traps in longitudinal and cross section?
The upper, did you say traps?
Yes.
Okay, great. So trapezius, which kind of dealt a little bit with what we looked at earlier today, or earlier in the session, which was the superficial structures over that supraspinatus fossa. I like to start most structures in short axis, and because this muscle, this trapezius muscle, is so superficial, put a bead of gel down, and that'll help you discern where does this muscle start and stop from the skin. So with that bead of gel, I'm not compressing the skin or the trapezius muscle. So here's our short axis trapezius muscle. And we can scan the muscle belly and make sure those fibers stay centrally located in the screen. And what you want to do is make sure that the fibers are not going oblique when you're scanning through this, because angle artifact can look like little areas of muscle fiber loss. But here's your trapezius. All of this up here, and then let's go long axis. I'm going to bring the left side of the screen lateral, and we're going to see the superficial aspect of what we scanned earlier today. So this is the long axis of the trapezius muscle here. I'm going to go down deeper. Bring our arrow back up here, supraspinatus muscle belly. Here's that fascia that the muscle needs to be very healthy and go right up to the fascia. and then here's the trapezius muscle and long axis. And you can just trace that out. It's very broad, it's very wide, but you can see how the fibers look nice and longitudinally oriented once you're playing with how you twist the transducer to get individual groups of that muscle and long axis. So you should be able to elongate the entirety of these muscle fibers really nicely. Neat question. It's not a part of a routine shoulder exam, but you should know where all this anatomy lives under your transducers so that you can more isolate pain generators where they are.
Right. Perfect. Well, that is all of our questions. And we're about 8 minutes over, so sorry for keeping everyone, but I wanted to make sure we got all those covered.
Yes, thank you for your time. That's good for me. Thank you for following along with this 4-part series. And if you missed any parts of the previous webinars, share them, social media, whatever. But they are also living at sonosite.com.
I have the page showing right now where you can see all the webinars. Okay, thank you everyone for joining us. We will see you at future webinars, and thank you for your time. Thanks, Daniel.